Hello, everyone. I am Dr. Muhammad Tawab Khalil, and I'm a second year resident in physical medicine and rehabilitation from Pakistan. And today we have two amazing guests, Dr. Levent Ozcakar and Dr. Jorge Barbosa. And today we will be actually discussing about the interesting ultrasound courses that are going to happen in ISPRM 2022. So Dr. Levent Ozcakar is a professor at Hacettepe University Medical School, Department of Physical Medicine and Rehabilitation at Ankara, Turkey. He is the founder and president of Turkish Musculoskeletal Ultrasound Study Group, as well as the European and the World Musculoskeletal Ultrasound Study Group. And he is also the founder of Ultrasound Study Group of ISPRM. Dr. Jorge Barbosa is a PRM specialist at Center Hospital, Lisbon, and he is the coordinator of intervention and ultrasound section of Portuguese Society of Physical Medicine and Rehabilitation. I welcome you, both of you, and how are you doing today?
Thank you.
Fine, thank you.
So actually my first question is going to be from both of you, and I want both of you to actually answer it. So I actually wanted to know that what actually fascinated both of you to start doing musculoskeletal ultrasound in your PRM practice, and how did your journey of musculoskeletal ultrasound actually started?
The first contact I had with ultrasound, it was during my residency, and in my department we didn't have ultrasound, but I started going to some courses, some national, international courses. But at the time there were few PMR departments in Portugal that had ultrasound machines. So one part of my residency, I went to a rotation in Mayo Clinic in Rochester, and had the opportunity to have contact with practice with ultrasound. And I was really, it was very enthusiastic for me because I love technology, and it was a way of improving patient care and to have direct talk with the patient, to directly act to the patient in diagnosis and therapeutics. And so that was one of the first steps. Then at the end of my residency, I went to another rotation in Spain, and I had opportunity during 1 month to do ultrasound training for every day. So that really changed my mind, and independently of my career, what could happen, I knew at the time that it had to be connected to ultrasound, because it is a great way to improve patient care.
Yeah, my journey is, little perhaps, considering the age difference between George and me, is perhaps a little backwards. I started in 1999. I was a resident like George in the second and the third year of my residency, and out of the blue, I don't remember how, there was a new installed machine in our department. Well, in those years, actually, it was a big problem for physiatrists to find machines. So we were lucky, and I was quite lucky. We had the machine, and then, you start playing with the machine, and you start checking the probe, and you start seeing, or you start trying to see what you can see in your patients. But then as long as you are aware that this is the continuum of physical examination, we are clinicians, we are not radiologists. So we are doing ultrasound as the continuation of physical examination, as George has mentioned. So after listening to the patient and then physically examining them, trying to put the probe and seeing what is inside the patient, what's going on inside the patient is you cannot, it's second to none. You cannot compare it with anything else. We're not surgeons either, so we don't have the availability to cut and see, but we sometimes see further than the surgeons because they don't cut and see the healthy structures. But when we put the probe on the patient, we can see in a static and a dynamic way what is going on inside the patient, unless it's inside the bone, okay? So this, in years, the awareness has already skyrocketed, but we were not that much lucky in 2000, in 1999, because there was less awareness, but now we don't have the awareness problem. The only problem, perhaps, having access to a machine in certain countries or in certain regulations, and perhaps less, but the lack of access to education. And this is actually what we're trying on our sites, trying to promote the training in ultrasound in physical and rehabilitation medicine, and leave the problem of finding the machine to our colleagues.
Yeah, Dr. Levent, I think you have just answered all my questions. But But I mean, it is very important to understand that for a physiatrist, ultrasound is an extension of clinical examination. I mean, it is like amazing when you get to see what actually is happening at the muscle, and you can see the pathology. It is just divine.
We are not a moment. We're not doing pancreas or thyroid ultrasound. We are doing tendon, ligament, and muscle ultrasound, and these should be assessed always dynamically. And this is also one of the reasons why we have also published the dynamic protocols for our working groups very recently. So it's I mean, there's no question for this. If you have the access, of course, you have to see inside the patient. I mean, when you see with your glasses, would you like to take it off and see less? Of course not. So you have the probe and you have to see inside.
Yeah, exactly. So, Dr. George, why do you think that musculoskeletal ultrasound is an essential tool for a PRM specialist?
Well, I think, like Professor Levent said, it's a dynamic exam. It's a clinical exam. It is not an exam that you do or a technician do, and then you go to have coffee, and then you do the report. No. You have to be on the side. You have to look at the patient. You have to first make a general consultation. You have to make a physical exam, and then to correlate with the ultrasound findings. There are even pathologies that we can just have the diagnosis when we do the dynamic testing. When you mobilize some region. Well, and I think because of all those aspects, it's a clinical exam, and at the office it gives us much more information, and that information is essential. It improves really our clinical practice. With information of ultrasound, we can select the approach, we can modify our rotation program, we can decide if it's to treat or not to treat. So when comparing a regular consultation or a consultation that we have an ultrasound equipment, to have all that information, I think there's a huge gap. And after you enter into ultrasound, then you don't want to go back. That's a very important aspect. Well, another advantage of the ultrasound is that you can do procedures, ultrasound guided procedures, because of all the information on the image. You can see where is the pathology. You can see what type of you can choose what's the best agent, therapeutic agent. And some years ago we just had steroids. Now we have a lot of therapeutic agents. We have a lot of techniques, as long as the technology keeps improving. So it improves our precision, the precision of our procedures. We can see where the needle is. We can avoid structures that we don't want to pinch. You can select the length of the needle, the caliper of the needle. You can choose if it's to treat or not to treat. So all of that aspects improves our practice. And if ultrasound guided procedure is due with ultrasound guidance, of course, it's ultrasound guidance. I think there's no need sometimes to take for long rotation programs. The patients can avoid taking medicines for weeks or for months. You can even help them to go back to work quickly. So these are advantages of ultrasound, and I think ultrasound is here to stay with us with our specialty.
We usually, Dr. Mohammed, we usually have a saying: if you would like to be free, and if you would like to provide freedom to physiatrists, you have to be doing ultrasound. And if you would like to be superior, and if you would like to produce miracles, you have to use ultrasound. As George has mentioned, I mean, it's very patient-friendly and physician-friendly as well. So you're interacting with the patient, and you are still going on your discussion, asking the medical complaints, and perhaps you are even asking, is it this place, or this place, or this place, the most painful area? And as soon as the patient points that place, you put the probe and you see something corresponding to that complaint. I mean, there is no more, let's say, or better specific and better sensitive imaging modality at the moment in medicine. So, full stop.
I totally agree with both of you, actually. So there are actually 2 ultrasound courses that are being conducted in ISPRM this time. And one of them is actually the beginner course, and the other one is the intermediate course. So can you briefly describe what are the learning objectives in each of the courses?
Well, the learning for the basic course, the learning objectives is to introduce ultrasound. To introduce the basic protocols for the shoulder, elbow, wrist, hand, hip, knee, and ankle, foot. We're going to have lectures about the principles and settings, physical aspects of ultrasounds. We're going to have live demos on those 6 regions. And we also going to have practice in the normal subjects. So I think it's the correct course to the beginners. All the course is based on the USPRM and neuromusculoskeletal protocols that were published by Professor Levent and his team some years ago. For the intermediate course, we focus more on pathology and in intervention, lower and upper limb. We're going to have lectures about pathology on those segments, all regions of upper and lower limb. We're going to have lectures about interventions and interventions with real videos, all about interventions made in real clinical settings. And for the private practice, in the course, we're going to have patients selected in the hospital with pathologies to scan and to see to confirm and to check for pathology. We also going to have lectures about spasticity and evidence for ultrasound guided procedures. Those are the main differences for the courses.
Yeah, thank you, George. I mean, he has mentioned more the actual content for this year. And let me say a few words about the general outline for our USPRM courses that we plan further in the coming years of ISPRM congresses as well. The first kickstart was given in Orlando before the pandemic, actually. And then we started with the single course, the beginner course. And we were planning to make it beginner, intermediate, and advanced. And we were not well enough oriented what we could be doing in Lisbon. But thanks with the local organizing colleagues, we could manage to do the intermediate as well. And in the coming years, probably starting with Colombia, there will be 3 simultaneous courses. So everyone attending ISPRM each and every year will be aware that, okay, if I go to this Congress, there are 3 simultaneous courses. Either I attend the beginner, the intermediate, or the advanced. So the final aim is to have 3 simultaneous courses, but this year in Lisbon, it will be beginner and intermediate, and the content is, as George has explained, will be more on pathologies and interventions on the intermediate side, and more on the basic beginners. They will be dealing with normal scannings of the 6 joints.
I think this is going to be a very unique and interesting opportunity for all the ISPRM specialists all around the world to get the hands-on practice on the patients, and they can practice actually the USPRM protocols as well, and then they can take it to their countries, and then they can teach it to other people as well. And I think this is going to be the best gain out of this workshop as well. So if I may ask, like, what are the interventions that are going to be taught in the intermediate ultrasound course?
Well, we're going to have a high range of interventions because the technology is also improving. Every year comes new therapeutic agents, new techniques. It's ultrasound guided procedures are really exploding and keep growing and growing and growing. So for upper and lower limb, for the regions, we're going to approach interventions on articular and periarticular, joint, bursa, ligament, tendon, and also in the upper and lower limb muscles, we're going to approach spasticity and nerve blocks. So it's going to be, we're going to talk about, of course, the regular steroid anesthetic injection, but as well as hyaluronic injection, PRP, bone marrow concentrates, nerve blocks, botulinum toxin, and also some techniques that use the mechanical advantage of the needle, like tendon releases, structural releases. So I think we're going to have a big range of interventions. It is going to be interesting for us, for everybody.
I might add a few words, if possible. I mean, George has mentioned about the types of procedures that we're going to discuss, but perhaps people might ask the question, yeah, but these topics are also given elsewhere, so why should I enter this course but not others? So perhaps the most important part of our courses is we are giving our philosophy. As George has mentioned, we are using our protocols, not only for the scanning, but also for the interventions. So for us as physiatrists, ultrasound imaging and guidance is equal and cannot be separated. I mean, when you see in routine literature or routine resources, you see, okay, many types of interventions. They are called ultrasound guided something, ultrasound guided something. But we prefer to say it's not ultrasound guided injection. It's that ultrasound guides the whole injection. So you start with the diagnostic part, and ultrasound sometimes will tell you, don't touch the patient. So depending on what you see on your imaging and examination findings, you tailor your procedure accordingly. And as George has mentioned, sometimes you change your mind not to go with steroids, but you just suffice to go with local anesthetics or with PRP injections. Or sometimes you even understand that it's actually contraindicated for that particular patient. So our philosophy is ultrasound imaging and guidance. It's together, and ultrasound guides the whole injection. It's not just a simple ultrasound guided injection. And regarding the botulinum toxin injections, it is again our philosophy of targeting the innervation zones, not just seeing the most bulky part of the muscle, but together with the histological studies in the literature, we have published our protocols where innervation zones are trying to be targeted during ultrasound guidance. So it is not the same thing that you can find anywhere else as ultrasound guided procedures. There are different things, and it's more based on our philosophy, neuromuscular USPRM philosophy, for different approaches. Okay?
Yeah, I think it's actually your philosophy that makes the philosophy that ultrasound is actually guides the procedure. It is actually this philosophy that is going to separate these basic and intermediate ultrasound courses from others that are going to occur all around the world. Because I mean, this is the philosophy that is actually, I think, unique to a physiatrist, because other people who are doing ultrasound guided procedures, they are just have this thing in their mind that they are going to go and just target this muscle or this tissue or this tendon, and that is it. But then this philosophy, it is actually something that is, you know, quite relevant, and it is quite unique to PRM specialists. So I am sure that it is going to be a worthwhile course, you know. So I want to actually know your views regarding the use of ultrasound elastography in tendon pathologies. What are your views about that?
Well, I think elastography can even improve the information that we have with regular ultrasound. If you're doing like a tendon testing, like the supraspinatus tests, and it is positive, it can be a tendinosis, it can be a partial tear, it can be a total tear, and ultrasound, you have that information. If you turn Doppler on, you can see if there's an inflammatory process or not. Well, what elastography brings us is to give information about the stiffness of the tissue, and that also can change our decision, and it's going to improve the information that we have to take our decisions. Well, if you do ultrasound exam with elastography, we can to see if a tendon tear, if it's in the beginning of process of healing, or it's of the tissue is like near the original tissue. And with that information, you can change the rotation program. Sometimes the patient don't have pain, and maybe you can have in mind to make like stretching, strengthening, eccentric, and then you put the probe and you turn the elastography on, and you see that the tear can be in the beginning of the process of healing, and that can change your decision. Well, with regular elastography, you can to see about its qualitative information. You look at the colors, if it's more the stiffness, if it's more soft, and you can change your region of interest and compare with the other regions of the tendon. And you can also, if you do another exam 1 month after that, you can do a follow-up and to check the response on the treatments. And in the last years, there's a more technological more improvement in elastography, that is shear wave elastography. With that elastography, we can have quantitative information, and you can select the region of interest, and you have physical units, that is pascals. With that physical units, you have much more precise information about the stiffness of the tendon. So I think elastography, it's a very useful tool and can improve the information that we have in the ultrasound exam.
Yeah, I fully agree with George. And again, I will try to take you back to the philosophy. We say that ultrasound is the sous chef in the kitchen, and the clinician, in this case, the physiatrist, is the master chef. So as the master chef, you have to know what features of ultrasound machine will give you what type of data. So if you are interested for that patient, and if you would like to know the elasticity of that tendon, you push the button and you make it on. If you're interested in the vascularity of that structure of the pathology, you push the button of Doppler or power Doppler and you make it on, okay? So you, as the clinician, is the master chef. Ultrasound is the sous chef, can help you in everything, but you have to guide it, okay? And just adding one more thing to what George has explained about the two different versions of elastography, the later one, or the more recent one, the shear wave elastography, decreases its user dependency, but even more than the B-mode imaging, elastography is quite user dependent, especially the older version, how you hold the probe and you produce vibrations. So we need to caution our colleagues saying that, okay, ultrasound is, okay, we are very much fond of it and we are really thinking that it's a miracle, but you have to be also knowing your limits, and then you have to remember that it's user dependent, and we have to avoid making so concrete comments before we really become experts enough to make judgments of those pathologies and patients. So don't forget, it's the sous chef and clinician is the master chef.
Yeah, I will take this thing with me, that ultrasound is my sous chef and specialist is the master chef. So thank you so much, Dr. Barbosa and Dr. Ozcakar, today for giving us time and discussing your both the work ultrasound courses that are going to happen on 2nd and 3rd of July in ISPRM 2022 at Lisbon, Portugal. Thank you so much for your time.
Thank you.
Thank you. Thank you very much for your questions. Thank you.
Thank you. Bye-bye.